Thank you for having me. I'm Teresa Mangin. I'm a movement disorders specialist at Dean Clinic. And so I mostly see Parkinson's disease patients and tremor and things of that nature. So if you came to the symposium last year, you heard a similar talk from me, so I apologize, but there hasn't been a lot of change in the past year. And we'll leave time at the end for questions. And I hope that you guys aren't getting sick of me yet. All right, so starting out with some goals of this next hour, I want to talk about why medications are important in Parkinson's, how they work, what symptoms are helped by them, and what symptoms are not as much helped by medications, what side effects can occur with medications, and why do they need to be adjusted so often, and then just as important as what meds you should take in Parkinson's are what meds you should avoid, and then whether it matters if you take brand name or generic. We'll kind of touch on all of these points. So to answer the first question, do I have to take medication? You know, it really depends on what your specific symptoms are and how long you've had them and how much they're interfering with your day-to-day function. So with early or mild symptoms, you probably don't need to take any medication for Parkinson's, as the treatments are really symptomatic. So if your symptoms are pretty mild and not bothering you that much, then it may not make sense, or you might not justify the risk of medication side effects at that point. One thing I would just want to get out of the way up front is that exercise is at least as important as medication, if not perhaps more so. And so that can be an early strategy that you would employ right away before you start a prescription. Up to this point in time, medications for Parkinson's are symptomatic treatment only. So what that means is that despite a lot of interest generated in neuroprotective therapies or disease-modifying therapies, there hasn't been anything that's been definitively proven to do that. And so mostly what we're trying to do when we prescribe medications are adequately address your symptoms so that you're able to maintain a normal level of function. So people who start medication earlier when needed, meaning that you don't hold off until you've been struggling with symptoms for a long time, do better in the long run. And we think that just means that when you start the appropriate medication and it allows you to maintain your normal activity levels to the extent possible, then it's that staying active piece that's so important in your long-term outcome. So I'll talk a little bit about how the Parkinson's medications work, and this is a complicated topic, but in general, they aim to restore a more normal balance of brain chemicals called neurotransmitters. And we know that in Parkinson's, neurotransmitter levels are lower than in somebody who does not have Parkinson's. Most of the focus is on dopamine, which is one example of a neurotransmitter, but there are other types of brain chemicals that are also affected by Parkinson's. So a lot of what the medications do is aim to boost the levels in the brain that are low and get them to a more normal range and in turn lead to better function. So dopamine is the principal neurotransmitter involved in Parkinson's motor symptoms and also the main one that we manipulate in treatment. Other neurotransmitter systems like norepinephrine, serotonin, acetylcholine are also important. So the last one there, acetylcholine, is an example of how too much is one problem, too little is another. So medications that decrease acetylcholine tend to help tremor. Medications that boost it tend to help memory. So it's an example in Parkinson's of how it's really important to strike a balance with many things so that, you know, too little or too much can be a problem. This is just a schematic of the dopamine, how two cells with involved in dopamine transmission work. And I don't want to spend oh, here we go. Okay. So this is a nerve terminal in which dopamine is being synthesized. So you see here kind of the steps that lead to dopamine being formed at the end. Now, this is nice because it shows how L-DOPA or levodopa is not exactly the same as dopamine, but it's like one step before it in the chain reaction. So it's the closest thing that we can do as physicians or pharmacists or whomever to give you the dopamine that's low. It's the closest we can come, and therefore it's really kind of the cleanest treatment, which means that it gives you the most benefit compared to side effects, because it's the closest way we have of restoring dopamine levels. So this cell is making dopamine. It stores them in these little synaptic vesicles. They come out to the end of the cell and they get released into a space between the nerve cells. And then the receiving cell has dopamine receptors. There are different types of dopamine receptors that have different functions. So this just shows D2 and D1 receptors. And then that sets in motion a whole chain reaction of events down the line that is important in normal movement, but also in mood and learning and other types of things. So that's just a little background about how that works. So as we were talking about a minute ago, the specific cells in the brain release the neurotransmitter in order to send a message, and then the message is received on the other end by cells that contain the receptors. And this communication between cells is pretty important for the brain to function smoothly. So we have different ways we can manipulate this to try to help people's symptoms. So receptors receive the message by binding the neurotransmitter, and they're very picky. You have to be very specific. So I always use this analogy that many of you have heard before of a lock and a key. If you think of the receptor as being the lock and the dopamine or whatever chemical that receptor is made for is the key, it's very picky. It has to fit just right to set that chain reaction in motion. So we can use types of drugs called dopamine agonists that mimic the structure of dopamine enough to unlock the lock. So it's not a perfect match. It's kind of like a skeleton key or something, and it's not as specific, but it will unlock the lock and fool the receiving cell into thinking dopamine is present, and that allows, more normal function down the line. You can also have the opposite, where you can have an antagonist that blocks the lock or jams the lock, so that no matter whether dopamine is there or not, it's not going to work on that lock. So that is an example how some of the psychiatric medications work. They have a dopamine antagonist effect. Some anti-nausea medications also do that, and that's why we don't like to use them in Parkinson's disease, and I'll talk a little bit more about that later. So here's a table that goes through the different classes of medications that we use for treating motor symptoms in Parkinson's. As you can see, there are many, many examples here, and they fall into roughly like 6 categories, which is the column on the left. So at the top there you have levodopa, which is still our gold standard of treatment for Parkinson's. It's the oldest and the best, and like I was showing you in that cartoon kind of slide, it's the closest thing we can give you to just normal dopamine, and your brain gets that in the cell, and it has a chemical that changes it into dopamine. So that's levodopa, and that's still our number one go-to drug. And it goes by brand names of Sinemet and Parcopa. In the generic form, it's always given with carbidopa, so carbidopa, levodopa. And the carbidopa part is what prevents the levodopa from getting metabolized in your body before it's able to cross over into the brain where we want it to work. So the carbidopa piece allows you to get more benefit from the amount of levodopa that's there, so you can have fewer side effects and get a better result because more of it is getting into the brain where it needs to work. So then we have the second category, probably second most potent type of drug that we have is the dopamine agonist class, and there are many examples of that. The 2 most commonly used are pramipexole or Mirapex and Ropinirole or Requip. The Nupro patch that's recently been back out on the market for the past couple years is also a dopamine agonist called retigatine. And that works by, again, kind of tricking that lock, that receptor, to thinking that dopamine is there. But it's not perfect, so it acts on more than one type of receptor, and maybe you don't, because of that, it can cause some side effects. And I'll talk about that later too. And then you have monoamine oxidase B inhibitors, 2 examples there, selegiline and rasagiline. And I'm just gonna hopefully not make anyone dizzy, but I want to go back to this for a second, because this shows how Once dopamine gets released into the space between the cells, it's cleared out of that space by two different chemicals. One is monoamine oxidase, and the other is COMT, or comethyltransferase. So those two chemicals clear out the dopamine, and if we block those chemicals with drugs, it allows the dopamine to remain in that space longer and act longer and work a little better. So if your dopamine levels are already low, and we block these chemicals that clean it out, then the net result is that you have more dopamine around. So that's how those two drugs work. And then we can use anticholinergic medications that help with tremor, and we can use amantadine that's kind of in its own category. It has many different actions, but that can help with tremor, it can help with alertness, it can help with dyskinesia. So a little bit more about levodopa. It's been around since the late 60s. And initially, before it was discovered that we could give carbidopa with it, it was given alone in much, much higher doses, and it was very difficult for people to tolerate. They often had nausea and vomiting with it. And if you've ever seen the movie Awakenings with Robin Williams, that was the subject of that movie. It was when they gave levodopa to people who had been stricken with encephalitis, and they had post-encephalitis Parkinson's. And that drug worked transiently in those people and really made a huge difference. So now we always combine it with what's called a peripheral dopa decarboxylase inhibitor. That's carbidopa in the United States, and in Europe sometimes they use a different one called benserazide. And it allows more levodopa to get into the brain and work well there. And it comes in many different combinations, and one source of confusion is what these numbers mean. But the first number always tells you how much carbidopa is there, and the second number tells you how much levodopa. So it's really that second number that we pay the most attention to. So there are some examples of what that medication might look like when you pick it up from the pharmacy. It depends on which dosage form and what brand and all of that, but it's still the most effective thing we have for the motor symptoms of Parkinson's. And one really, really common question that I get is whether you'll get tolerant to it, meaning that like if you use it now, you won't be able to benefit from it later. And that's not the case. It does not produce tolerance. It can produce complications, like on average after 3 to 5 years of treatment, people can develop some involuntary movements from the levodopa that we call dyskinesia. And then you can also experience some ups and downs or fluctuations of feeling the meds kick in and wear off. But that is not really a sign that it's not working for you anymore. It's more of a sign that we're having to go a little further to meet the gap between how much dopamine the brain is making and how much your brain needs. And so over time, that gap widens, and we need to make up for it by increasing the doses and so forth. So dopamine agonists, we talked a little bit about how those work, and they kind of trick the brain into thinking dopamine's there. And this just shows kind of a schematic of that, with specifically talking about the patch, but it's the same idea for any of them. So here's like a scenario where the brain's not making enough dopamine, and so not enough of that chemical is coming out into this space between cells, and so not enough of it's around to bind to these receptors. This is the normal situation, and here's what would happen if you use a dopamine agonist. You get, it's not the same exact thing, it's not the purple, it's a green, but it'll also work. And so that's, again, just to reiterate how that works. So we use those very frequently as an initial or early therapy prior to starting levodopa, and especially in younger patients, I would employ this strategy, because we think that if we start with this and it buys us a few years or whatever before we start levodopa, that the long-term risk of developing dyskinesia would be lower in those patients. The dopamine agonists also work a little bit longer than levodopa, and they're really helpful for things like restless leg symptoms, even in patients who don't have Parkinson's disease. And they can be helpful for smoothing out ons and offs that you can have with a levodopa alone. So they're often used alone, but also in conjunction with other meds for Parkinson's. Unfortunately, though, they have some side effects that can be difficult to tolerate. So very commonly, they can cause fatigue, nausea, even vomiting. They can cause some cognitive side effects. I think the age is one risk factor for that. So, the older that somebody is when we start these drugs, kind of the more risk of the cognitive side effects like confusion or hallucinations. They can cause a little bit of ankle swelling. And, unusually, but importantly, they can cause behavior changes or what's called impulse control disorders. And we think this happens in about 10 to 15% of people on these drugs, and that might be an underestimate. But it can be weird things like gambling or compulsive shopping, sexual addiction. And so those are really disabling side effects that we would, if I get a hint of that, then I pretty quickly try to get people off these drugs, because it's not like a willpower issue. The drug is acting on those dopamine receptors, and dopamine's also important for learning. So say you're at the slot machine and you're losing, like a normal brain is going to say, stop playing. But if you have dopamine agonists on board, they're filling those receptors. Your brain is getting this like positive feedback, and it's not going to tell you to stop playing the slots. So that's a little kind of just a hint of why that happens. Okay. So there are some pros and cons of dopamine agonists versus levodopa. In general, the dopamine agonists work longer, you have less dyskinesia, but on the flip side, they can cause more confusion and more fatigue. So where the levodopa is more potent, less side effects, but more dyskinesia. So it's always some kind of a trade-off. So I'll just really quickly touch on apomorphine. It's also a dopamine agonist, but I use this very, very infrequently. It's more of a rescue drug. It's injectable. And it's very short acting. So it's only used for people who have really unpredictable offs that occur despite taking your Parkinson's medications regularly. And so it's used as a rescue, but it's really not, I think, it's not really that practical. And usually we can address offs by making medication adjustments that would obviate the need for this. The first time it's given, it has to be given in a supervised, doctor's office setting, because it can cause really low blood pressure. Feel free to, if anyone has questions or... Hi. Oh, good. Okay. So, we still have plenty to go, but if you have something that's like burning question that you need to know before I go on, then let me know. So I'll kind of glance over these and see if there's anything relevant to what I've just said. Oh, great. Lots of questions. Okay. Thanks, Jane. Okay. So the next category I would like to talk about is the monoamine oxidase B inhibitors, which are selegiline and rasagiline. And they prevent that breakdown of dopamine in the space between the cells. So they prolong the action of levodopa, and that can make your medications last longer. Selegiline and rasagiline can be used as monotherapy, meaning by themselves without other medications. And there has been a lot of interest in whether these drugs have what's called a neuroprotective benefit, meaning could they slow down the progression of Parkinson's. And I think that if you ask, 20 movement disorder specialists, you probably get 10 yeses and 10 nos. It's kind of controversial whether it has that neuroprotective benefit. That hasn't been definitively proven, and the FDA does not think they've met that standard to prove that. But these drugs are pretty well tolerated, and the rasagiline's only once a day, and so many people would prefer to hedge their bets and just take it, because it gives you definitely a little symptomatic benefit, and it might help with slowing disease progression. So there you have it. And I put a picture there of the wine and the cheese just to remind myself to tell you that if you get these drugs from the pharmacy, you'll get a big warning that you can't take them with certain types of antidepressants. You can't drink red wine. You can't eat aged cheese. But that is really not accurate. It's a theoretical interaction that pertains to monoamine oxidase A inhibitors, and the FDA just groups those drugs together for the purpose of listing side effects, and so you really don't have to worry so much about these interactions with the ones that we use in Parkinson's. So similar, the COMT inhibitors also prevent dopamine breakdown in that space between cells, but different than the MAOB inhibitors, these are only given along with levodopa, so they are not used as monotherapy. There are two examples right now, entacapone and tolcapone, and the entacapone comes with carb-levo in a combination pill that's called Stalevo, and it can also be given alone. And they're used to reduce off time, so that say you're taking your meds every 4 hours, but you feel like they're only lasting 3 hours between doses, and you have an hour of off time before each dose is due, then one strategy would be to add this and see if you can retain that 4-hour dosing interval without moving your meds closer together. They can sometimes cause diarrhea or discoloration of the urine so that the urine looks darker. And tolcapone, which is a little bit more potent than the entacapone, requires blood work for monitoring liver function. These are some examples of Stalevo, and Stalevo comes in a bunch of different doses. It's always named for the amount of levodopa that's in there, so a Stalevo 75 would have 75 milligrams of levodopa. A Stalevo 150 would have 150 milligrams of levodopa. And they always have the same amount of entacapone, which is 200 milligrams. So that's kind of a standard dose. And then so I think it comes in 75, 100, 125, 150. So there are more dosing options with Stalevo, which is kind of nice compared to the levodopa, which you can only do 100 or a 250. So then amantadine, it's kind of its own orphan drug in its own category. It has a little bit of dopamine agonist effect, but it also works on other neurotransmitters like glutamate. And it's used sometimes as an antiviral to shorten the duration of like the flu, for instance. But it can be used in early Parkinson's as monotherapy, or especially for tremor. I don't use it that often as monotherapy unless somebody really just strictly is bothered by tremor. It's not quite as good for the slowness and stiffness that can occur in Parkinson's. But it can be helpful as an add-on later on if you've developed dyskinesia or wiggly movements from the meds. It can be helpful in reducing that. And on the side effect side, it can cause a rash called levato reticularis, which looks like a lacy kind of rash. It's a little hard to see on here, but well, anyway, you see a picture of a bent leg there, and it's kind of a red lacy rash, but it's not dangerous. It's just, sometimes people don't want to live with that, so we would stop the medication. Anticholinergic drugs, which are pretty strictly helpful for tremor, I use these very infrequently because they're so difficult to tolerate. They cause cognitive dysfunction, constipation, urinary dysfunction, dry mouth, confusion, so we would never use them in someone over, say, like 65 or so, just because the risk of side effects is really too high. I mean, it's really high even in younger patients. So, but if somebody has a very difficult to control tremor, that might be one strategy to employ. Then there are some alternative therapies. There used to be a lot of interest in coenzyme Q10 as a type of like antioxidant. And initially it looked like it might be helpful in slowing down disease progression in Parkinson's. But when they did some follow-up studies on this, it did not bear out. And so it's no longer really recommended, and it's quite expensive to be on the doses that we used to recommend, which was like 1,200 milligrams a day. So I have a few patients who still take it. I mean, it's safe and it might help other things, but it so far doesn't look like it's going to be the way to go for Parkinson's. And then there's an herbal version of levodopa called Mucuna, and you can get this like from a naturopath or like an alternative medicine practitioner. But the active ingredient in that is levodopa, and it's a little harder to titrate because you don't have the carbidopa with it, and you don't have as strict of oversight over how much is in each pill. So some people prefer the idea of this because it's kind of a little more natural, but I think if you're needing a symptomatic treatment, then my bias would be to go with something a little bit more predictable. But I'm open to people trying that, and sometimes that's a good initial therapy. So there are some things that really should be avoided in Parkinson's. I mentioned before nausea medications like Phenergan, Compazine, and Reglan or metoclopramide. And the reason is that if you think back to that lock and key analogy, these drugs are antagonists at the dopamine receptor. So they block the dopamine receptor so that whatever dopamine your brain is still making or that you're taking via levodopa or another prescription is not able to work well, so it can actually exacerbate or sometimes even cause symptoms of Parkinson's in patients who don't have Parkinson's. So we really try to avoid those. And if you needed something for nausea, we would use Zofran or Tigan. The same type of reaction can occur with antipsychotics like Haldol, Risperdal, olanzapine. And so that is why some psychiatric patients who have been treated for years and years for schizophrenia or bipolar disorder or something like that on these drugs, they can look for all the world like they have Parkinson's, and it can be very difficult for us to distinguish that clinically because these drugs are blocking the action of dopamine in their brains. And so there is a special type of scan we can do to distinguish that that will tell us how much dopamine the brain is making, whether it's normal or low. And that can help us tell if somebody has strictly drug-induced Parkinsonism or what we would call like idiopathic Parkinson's, where the brain's not making enough dopamine. So if somebody has hallucinations or things like that and they have Parkinson's, then we would prefer either quetiapine, which is Seroquel, or clozapine, which is Clozaril, because those drugs don't have as much of the dopamine blocking effect on the receptors that are important for movement. So those are relatively safer from a Parkinson's standpoint. Certain pain medications can be problematic in Parkinson's. It's hard to avoid narcotics, but you're going to be more vulnerable to the side effects of narcotics if you have Parkinson's, meaning like potentially confusion or hallucinations. Morphine tends to be better tolerated than Demerol, which is a synthetic type of opioid. So those things have to be used with caution. So then there's a whole host of other types of medications in Parkinson's that maybe address things other than motor symptoms like cognition or alertness. We talked briefly about antipsychotics, antidepressants. Because constipation is a common problem, we use a lot of stool softeners and laxatives as part of somebody's medication regimen. And then there are treatments for urinary dysfunction and blood pressure issues. Let's see. Here's a common medication-related question. Say somebody is on like 4 or 5 different medications for their Parkinson's because they've had it a long time, and over the years things have been added for different symptoms, and they come in and they've developed some hallucinations. Most often what we hear is that like it's not threatening, but you might look at a pattern on the carpet and think that you're seeing a face, or that something's moving and nothing's moving, or difficulty distinguishing dream from being awake or something like that. So we would look at the meds and streamline them in a specific order. We'd first, if there's any anticholinergic on board for the tremor, then that would be the first to go. Then we would take away amantadine. Next would be the monoamine oxidase and COMT inhibitors. And then the dopamine agonists, and levodopa would be the last to go because that really has the best ratio of benefit compared to risk of side effect. So that is something that comes up from time to time. There are medications to boost or enhance cognition. For memory specifically, we would use cholinesterase inhibitors. These drugs were really developed for Alzheimer's disease, but they're at least as effective, if not more effective, in Parkinson's disease. And they can help not only kind of sharpen memory, which isn't always the most difficult problem in Parkinson's, but they can reduce hallucinations also. So sometimes if I've already streamlined the meds according to that plan that I showed you a minute ago, and somebody's still having hallucinations, before I started an antipsychotic medication like Seroquel, I maybe would try one of these, donepezil or Exelon, to see if that alone helped reduce the hallucinations, because that has less of a sedating effect. They can cause some nausea, vomiting, diarrhea, and theoretically they can increase tremor a little bit. So again, that's where you have that tremor memory dichotomy with the acetylcholine. And then there's another drug called memantine or Namenda that works, that's approved for Alzheimer's. It has been used in Parkinson's quite, widely, but it really doesn't look like it's too effective in that context, and so I've kind of stopped using much of that. Thank you. Sleep medications, that's a good topic. Let me see if I have that here. So hallucinations, two options there, Seroquel and Clozaril. Seroquel is sedating, so sometimes that's a good thing if you need something to also help you sleep at night. Clozaril is definitely more effective and potent, but it requires weekly blood work because it can lower your white blood cell count and pose a risk of infection. So those are the two options now. There's a drug that's looking very promising in clinical trials called pimavanserin, and that works on the serotonin system instead of dopamine, and that's looking good for reducing hallucinations in Parkinson's, and it's in phase 3 clinical trials, so the jury is still out on that, but that looks good. Antidepressants, there isn't really any one class that you have to go to. Like, depression's a very common feature of Parkinson's, as can anxiety be, but we don't, at this point in time, have a unique treatment approach. We would still often try drugs like SSRIs, like Prozac, Paxil, Zoloft, those types of drugs. There are, depending on whether someone's experiencing difficulty sleeping versus like trouble sleeping or sleepiness during the day, then we might, choose one that would fit best for that person's symptoms, but there isn't a Parkinson's specific one. So constipation, I won't talk too much about this. If you're a patient of mine, you've probably heard me talk about it already. So we do like to stay on top of that in the sense that you don't want to wait until it gets to be a severe problem and then use a laxative. You'd rather kind of prevent the problem, and stool softeners are safe to take daily in Parkinson's. Urinary problems can be really challenging because the drugs that are used to increase bladder tone and help with continence and so forth can cause some confusion or memory difficulties. So those have to be used cautiously. But they're usually I just try to make sure with urinary problems, the most common thing I hear is that people are waking up frequently at night to go to the bathroom. And sometimes that can be helped by making sure that you're not too off overnight. So sometimes, like if you take your last Parkinson's medications at supper time and you're not taking another dose till the next morning and you're urinating frequently during the night, one factor is that you've gone so long without any dopamine. So we can sometimes address that by using like a long-acting Cinemed at bedtime or something like that, and see if that helps a little bit with the urinary symptoms. So that's just a little side note there. That blood pressure sways, like ups and downs, can be a problem. The Parkinson's medications can have a blood pressure lowering effect, and so sometimes if you are on medications to treat high blood pressure, you can actually come off of those or reduce the doses. And still sometimes we struggle with the blood pressure dropping too low when the Parkinson's meds kick in, and then we have some strategies to deal with that, like making sure you're well hydrated, maybe taking a smaller dose of the Parkinson's meds more often rather than a big dose less often. And this is, commonly triggered by like hot weather or eating a large meal or anything that's gonna divert the blood flow from your core. So that is a challenge, and there are drugs that help to boost the blood pressure. So sometimes people will take Florinef to help you retain more fluid so that can keep your pressure up, or midodrine, which causes the blood vessels to constrict to keep the blood pressure up. So generic versus brand name, I really don't have any issue at all with generics in Parkinson's. Some individual patients notice that a certain manufacturer of a drug might not work as well for them, and so then we can request that they avoid that particular manufacturer or whatever, but generics are fine, and if prescription costs are an issue, definitely I would encourage you to talk to your prescribing doctor, because, just from my perspective, I often have no idea what you're going to get charged for something once you get to the pharmacy. And usually we can arrange your medication regimen should not have to be financially burdensome for you in Parkinson's. There are enough generics out that we should be able to work with those. So let me read some of these questions, and then if we have more time, I'll drone on a little further. So one question here is, does vitamin B6 help with anything pertaining to Parkinson's? Not that I know of, not that we have seen in the research setting or anything, but it is important to make sure you're getting those B vitamins in general. They can be helpful for mood and all kinds of things, but there isn't anything Parkinson's specific about vitamin B6 to my knowledge. Could you please comment on sleep medications to give and to avoid in Parkinson's? This is a great question because it's such a common issue. I think if somebody's having problems sleeping in Parkinson's, it's really like a puzzle to figure out, because there are many things that could be contributing to that. One of them I mentioned is having to get up frequently to go to the bathroom at night. And some people have trouble falling asleep, and some people have trouble staying asleep. And then there are symptoms that are kind of unique to Parkinson's, where you can, act out dreams or talk in your sleep, or, really thrash around and have vigorous movement during the night that you may not even be aware of by morning, but that can affect the quality of your sleep. So it depends, you always, as a physician, you always have to try to take a pretty careful history of what's going on. Like, what's your routine? Are you going to bed the same time every night? Are you getting up the same time every morning? Or is your spouse noticing any of these active dreaming behaviors? How many naps are you taking during the day? So all of that is kind of important to address before we talk about meds for sleep. But then if, we're trying to stay active during the day, not taking a lot of daytime naps, and still having difficulty at night, then usually my first line treatment would be melatonin, because it's pretty mild. The downside of that is that for some people it doesn't do anything, but it's very mild, no real significant side effects with melatonin, and that you can get over the counter. And there are a lot of different dosages, but you usually want to start at least 3 to 5 milligrams and see if that helps you retain those day-night rhythms a little bit better. So the way melatonin works is that your brain releases that at night as part of your circadian rhythm, and in Parkinson's and as we age, that level drops. And so by boosting it with a supplement, that can help sometimes. Sometimes that's not enough to help, and so then we would look at like a prescription such as trazodone or mirtazapine. Those are both examples of non-habit-forming sleep medications that are in the category of antidepressants, but when we're using them for sleep, we're often using lower doses than would be used in depression. And the goal there is that they help you maintain your sleep better. So even if you're falling asleep okay, but if you're waking frequently during the night, then using these medications can help maintain a longer duration of uninterrupted sleep. So those are, some of the ones I use more commonly. If somebody's having sleep problems and, hallucinations or something at night, then we might try Seroquel. I usually don't like the idea of Benadryl or Tylenol PM, Advil PM. The ingredient there is an antihistamine called diphenhydramine. And some people can tolerate it okay, but it really can cause a lot of confusion and even trigger some hallucinations. So I don't really love that option, although I know a lot of people do that because that too is over the counter. And then I try to avoid things like Ambien or Lunesta or those types of drugs, just because if you're needing something every night, which may be the case if you have Parkinson's, those drugs might work for a while and then stop working. And they can also predispose to some really odd nighttime behaviors like sleepwalking, sleep eating, things like that, that you might already be, a little bit prone to because of the Parkinson's, and we don't want to make that worse. So I hope I've addressed that question. What medications for blood pressure or diabetes may affect the medicines I take for my Parkinson's? Well, I talked a little bit about how the blood pressure interaction can happen. Like sometimes people used to need more blood pressure meds than they get on treatment for Parkinson's. You might not need as many or as high of doses, but there aren't really any contraindicated drugs for either diabetes or high blood pressure and Parkinson's. So, just talking to your primary care doctor and making sure that everybody's aware of everything that you're taking, both your neurologist and your primary care, so that they can see the whole list. But there isn't like anything that you should really not take for blood pressure and Parkinson's. I guess some of the calcium channel blockers like amlodipine or that's the only one that comes to mind that ends in a pine. Those are listed as potentially being able to cause a little bit of tremor, but I haven't seen that as a big issue. So that would be maybe the one little asterisk that you would, maybe a beta blocker would be better than a calcium channel blocker. But there is a little bit more evidence that diabetes and Parkinson's are probably linked. We don't really understand how yet, but if you have diabetes, your risk of Parkinson's is higher than if you do not have diabetes. And I think I would go so far as to say, we'd really want to work towards tight blood sugar control if you have diabetes, because things like elevated blood sugars are thought to be kind of inflammatory, kind of pro-inflammatory in your body, and inflammation is bad in Parkinson's. We think that it hastens disease progression. So if you have diabetes and Parkinson's, you want to really be tightly controlling those blood sugars. Hopefully you would be anyway, but okay, what else? Let's see. Should I feel the effects of the carbidopa soon after I take it? How do you know if it's working or not? This is pretty variable. It kind of depends on how long you've had Parkinson's and what your symptoms are, because I think most people, when they first start taking medications, don't feel any kicking in and wearing off, and that's a good thing, and that's normal. It doesn't mean that the meds aren't doing anything for you, but you don't necessarily feel each dose. I think when somebody has a lot of tremor, then it's different, because if the meds work for the tremor, you can really see it kick in because the tremor quiets down, and then the tremor may return before your next dose is due. But it depends. So I would say, to answer this question better, I'd have to know, what are the symptoms that you're taking it for? Is it slowness and stiffness and walking? And if you're not seeing any improvement on meds compared to before you started them, but you're not having side effects, then the next step would likely be to increase the dose a little bit, because it might just not be enough of a dose for you. But if you feel like overall you're better on the drugs, but you just don't feel each individual dose kicking in, then that's probably okay. And we wouldn't necessarily increase the dose. You might not actually feel like you're without it unless you missed more than a day or two. So everybody's a little bit different, but it's not unheard of that you wouldn't feel the kicking in and the wearing off. All right, thank you so much for having me.
Thank you, Dr. Mangin. Can we have a round of applause? And thank you for coming today. We appreciate it. We support you. It was a great turnout. We're just glad you came. Have a nice afternoon.